was like over 30 minutes before they were able to see the bilateral ureteral jets. So I think that that definitely prolonged the operating time. But I see your point. Definitely, colpoclysis is usually a quick procedure, and that's why it can be preferred in these older, more frail patients.
And specifically under spinal, that's the idea. That they don't get general because they do poorly sometimes under general anesthesia.
One thing I'll say about what I've recently started with colpoclysis is I do them under MAC, just sedation, because it's most of the time it's a very superficial, especially if they're not getting a vaginal hysterectomy. So it's just MAC sedation with a nasal cannula and just some local anesthesia as well, and the patients bounce back really well from that type of procedure.
I am surprised that Morgan describes dissecting away the entire vaginal mucosa as a quick procedure. Can you comment on that? Is it because these postmenopausal vaginas are so small? I would expect so much bleeding. Is that because I'm normally seeing 25-year-old vaginas?
I think that when we do the hydrodissection with lidocaine, that decreases the bleeding significantly. And I think compared to other procedures like a sacrocolpopexy or something, I think that that's why we think a colpoclysis is a relatively quick procedure.
Yeah, you make really good points, actually, because colpoclysis technically does have more bleeding than some other urogyne procedures because you're getting into those planes. But overall, it's really not a lot of bleeding because the tissue is also atrophic. So between the atrophy and the fact that we really hydrodissect with the diluted solution of lidocaine with epi, they tend to not have bleeding. Tends not to be a major issue as it would be in trying to get into that layer in someone who's younger and premenopausal. But sometimes the procedure, depending on the size of the prolapse and how much epithelium you have to remove, and depending on also the quality of the epithelium, sometimes it comes off very easily. Other times, because it's been exposed and out for so long, the tissue may not be as cooperative. It can take a little bit longer.
All right, with 60 seconds left, Dr. Merjanian has a question.
Morgan, what was the explanation for the spontaneous resolution of the rectal prolapse?
It's a good question. I don't know that we have a definite explanation. I think everyone was very happy for this patient that it resolved spontaneously and that she didn't need another surgery. I don't know if it was just like the natural adjustment of her pelvic floor to the new anatomy after the colpoclysis that over time it spontaneously resolved. I think that's the current theory.
Potentially less edema post-operatively, because she did have a very big prolapse that needed to be reduced. So potentially less edema after, with the edema resolution, perhaps less pressure.
All right, well, let's end it there. We're just about out of time. Morgan, thank you so much for an excellent job as always. All right, it's time to switch gears and talk about grand rounds. In just a minute, I'm going to ask Dr. Bayat to introduce our grand round speaker. But in the meantime, just a brief announcement. For those of you who weren't here, I think it was last week or the week before, I was asking everyone to always sign in with your name. Unless you have an extremely unique first name, it would be very helpful to me and Michelle and Beth if you put your first and last name, which it just seems to be getting more and more common in conferences like this, to be helpful to the administrator who's running the meeting, for you to identify yourself properly. Last week, someone signed in with a number that had one more digit than a phone number, and I asked them to identify themselves and they didn't, and so I booted them. And so I ask all of you, please always try to identify yourself correctly, or if you're calling in, you can send a text to one of us saying who you are. It's much appreciated. And if you find out someone got booted, just tell them that I tried but they didn't identify themselves, and so that's why I booted them. All right, well, Dr. Bayat, are you ready to introduce our speaker?
I am ready. Can you hear me okay?
Yes, loud and clear.
Okay. Good morning, everybody, and thank you so much, Dr. Wong, for joining us today. I know it's early for you in California, so we're even more grateful for the opportunity to be able to hear you this morning. Dr. Wong currently serves as an assistant professor in the Division of Maternal Fetal Medicine, as well as in the Division of Informatics at Cedars-Sinai Medical Center. She did her undergraduate studies at Columbia and then went on to the University of Texas Southwestern Medical Center for medical school. She did her residency at the University of Chicago and then went on to complete a fellowship in medical education prior to pursuing another fellowship in maternal fetal medicine and obtaining a master's in health delivery science. Her prolific research career has also led her to the NIH, where she works as a staff scientist in the Office of Research on Women's Health. Her research interests in the use of artificial intelligence to reduce disparities in maternal morbidity and mortality is not only necessary, but so creative and timely as it involves using modern technology to tackle the age-old inequities and injustices from which the very practice of OBGYN emerged. She's an amazing example of just how important women are to the field of medicine and how thoughtful and profound their contributions are. As a woman in medicine myself, I'm particularly proud to see another woman excel in such a significant way. And I'm so happy that our many learners today can witness firsthand the incredible successes, accomplishments, and creativity that has characterized Dr. Wong's career. Dr. Wong, welcome again, and it's our privilege to be able to learn from you today.
Very kind of an introduction. Thank you so much. So I did share a little poll. I'm not sure how many can see it. I think that I will not be able to see it in a few minutes once I start sharing again. So sorry for the clicking on and off of sharing. But let's go ahead and get started. So thank you so much for being here. And it is early, but actually the NIH job means I don't infrequently have meetings at this time. So hopefully we can swing it. So just to start with the good old disclosures here, tragically I have none, hence still driving a minivan. But our objectives. So we're really just going to talk about data, sort of how we process it, and then how ultimately we generate biases off of it. We're going to move on to disparities, particularly, of course, as they exist in OB, and then ultimately describe how the biases we have inform those disparities. And that if we don't address them, especially with sort of my love of AI and how things get messy, how we might ultimately codify these, which can then make them truly dangerous. And then finally, as epilogue, because honestly, my wife initially said this talk was too depressing, what do we do about it? So then starting from sort of the get-go here, what is data? Well, this is how T.S. Eliot described it way back in his 1934 poem, The Rock. Where is the life we have lost in living? Where is the wisdom we have lost in knowledge? Knowledge in information. The cycles of heaven in 20 centuries bring us farther from God and nearer to the dust. And tragically, that beautiful lyric has been distilled to what is now known as the Dick W. pyramid, which is taught in basically every computer science or big data 101 class, which is that we start with data, and then from understanding relationships in the data, we can get to information, understanding patterns, and that information gets us to knowledge, and principles from that knowledge gets us to wisdom, or in funny Twitter form, something like this. But actually, I would suggest that it's in that element, in the synthesis of data, where things do get tricky, because now we're bringing those knowledge, attitudes, and beliefs into play, and those knowledge, attitudes, and beliefs can be messy. So how does that happen? So for the first part of this talk, I'll be referencing heavily this book, Thinking Fast and Slow by Daniel Kahneman, and based on the work that he and Amos Tversky did for about the first 50 years of cognitive psychology, and for which he ultimately won the Nobel Prize. It's an incredible book. It's incredibly dry. I do not recommend the audiobook for this on a long drive. So the sort of pop psychology research appropriation version, there's always Malcolm Gladwell, or for the kind of interpersonal Moneyball version, you've got The Undoing Project. But without further ado, let's actually get into it. So I'm going to click through a few things here, and I want you to say what comes to mind to yourself or out loud. No judgment. So each of these actually represented a method of thinking and a methodology from two different systems, System 1 and System 2. And so what are these? So System 1, Kahneman refers to as the storyteller, sort of continuously constructing a coherent interpretation of what's going on in the world at any instant. The storyteller is ultimately involuntary, immediate, sort of confident, occasionally wrong, some of which gets it a bad rap, but the reality is it is the workhorse of the two, and appropriately so. It's appropriate that if you were previously burned on a stove, you approach glowing iron with some trepidation. It is literally always on. System 2, on the other hand, is our slowdown system, right? It's voluntary, it's conscious, it's kind of how we think. It's also inefficient, right? So the System 2 is really this idea of subjectively experiencing agency, choice, and concentration. And so then as we swing back to this slide and we sort of think about how it felt, each of these, 1 is again effortless, so effortless you can't turn it off. You can't read 2 + 2 and not think 4. You can't read the capital of France and not picture yourself in Paris. On the other hand, focusing just on 17 times 24. So at System 2, I think most would agree there's nothing really immediate about knowing 17 times 24. But you can activate System 1. So for example, is the answer 123? No. Is it 16,241? Again, no. Then you couldn't probably immediately say if it was 568, or wasn't. It's not. But now if you were to try to answer it, so to really sit down sort of without your phone and put the numbers to paper, it's 408. If we looked at you at this moment, your muscles would be tense, your blood pressure and heart rate would be increased, your pupils would be dilated, and then when I gave you that answer, it would all sort of contract back. And so as a result, System 1 ends up, again, doing a lot of the work. That sort of impressionable, fast-thinking, confident version of us, that's the one that's always on. And so now let's talk about how these systems contribute to bias. And bias is commonly defined, or at least I always sort of grew up thinking of it as like a bad word, right? Like it's got like prejudice, so that's not a good thing. But in reality, if you read the cognitive psychology literature, it's really as unemotional as this, a systematic error, or Kahneman might call it a System 1 connection error. Cognitive biases are the same, but specific to our way of thinking. So I really like this idea of blind spots. So I don't think I've been in the car with anybody on the grand rounds today, but I'm a very active driver, especially as I've moved to LA. I didn't mean to cut off the person when I switched lanes. They were just in my blind spot. It doesn't make me any less of a jerk if I did it, or less my fault if we get into a fender bender, but it wasn't like I was intentionally going fast and furious on them. And where bias represents a systematic error or blind spot, then heuristics represent the shortcuts we take, or again, specifically that our System 1 takes to make sense of it. There are so many biases, in fact, that we can even group them together into this beautiful cognitive bias codex, which is just a lovely schematic representation of all the ways that we make errors, so many to choose from. And in a couple slides, I'm going to reflect on some of these and particularly how they might affect us in medicine. But I can't move on without highlighting one of the funner ones, including the IKEA effect, a cousin to the sunk cost fallacy, in which you value something more when you've had a hand in building it, particularly with an infinitesimally tiny Allen wrench. So if those are the biases, again, heuristics are the shortcuts. And the thing is, heuristics in healthcare are rampant. Dr. Claire points out in her bias talks that we are taught on these shortcuts. You score better with these shortcuts. This is a whole Twitter thread just of examples of these. You know, can a gay man in a question stem not have HIV, AIDS, or a sexually transmitted infection, give us lupus or something? And so again, while there are really too many of these, of course, to go through, including too many that apply in medicine, I'd like to focus on a few that I think we're particularly guilty of and for which there's literature to back it up, and particularly within OB. I'll also mostly pick on our own, although don't think that there weren't certainly plenty of examples, let's say, in surgery as it comes to overconfidence bias. So this is the tendency of people to be more confident in their own abilities than is objectively true. And this is a fun study. So they basically took 107 radiologists and they showed them a bunch of AP chest x-rays. And they had them choose a really sort of a basic level. Don't make the diagnosis, but just tell us sort of normal, abnormal, and if it's abnormal, then does it need follow-up or not? And lo and behold, while there was significant difference in performance, you can see here the accuracy in the top 20 was 95%, and in the bottom 20 of 75%, there was little difference in confidence. And in fact, those who were least accurate were actually the most confident, a phenomenon called the Dunning-Kruger effect. But while that study was sort of done in the theoretic, right, reaching out sort of artificially to radiologists and asking them to score chest x-rays, this has actually been shown in real clinical practice, specifically in real clinical OBs. So this study, actually done by Dr. Yeat, Northwestern, looked at OBs and separately looked at their test scores on cognitive and affective traits and their real clinical outcomes. And they found that those who were more tolerant of uncertainty, which was in this codified as overconfidence, seemed to have higher rates of postpartum hemorrhage and chorioamnionitis. And I think that our brains can sort of take that story on it and make it make sense. Next, the availability heuristic. So this is a mental shortcut that relies on immediate examples that come to a given person's mind when evaluating a specific topic, concept, method, or decision. Or in other words, this patient has whatever the last patient who looked like this or whatever was commonly discussed. And again, there's objective demonstrations of this. So after a grand rounds on a topic, lab orders corresponding to that topic go up. After a patient in the ICU dies because of a missed pheochromocytoma, suddenly everybody's peeing metapnephrine's until proven otherwise, regardless, of course, of the fact that the numbers haven't actually changed. Moving on now to confirmation bias, or the tendency for humans to resolve their cognitive dissonance by basically seeking out information that confirms their own belief, or as patients who have come to certain beliefs linking autism and Pitocin call it, doing one's research. But lest again, we think that's just sort of hoi polloi stuff. This is one of my favorite examples from the medical literature, an old study conducted back in 1977 of that hallowed institution peer review. So what they did with this is they took 75 reviewers, they sent them all the exact same study, the exact same methods to the study, where the only difference was whether the results of this fake study agreed or disagreed with what they knew to be these reviewers' sort of preconceived beliefs. And so then when they were asked to comment again on the methods, or as residents would call it, the skipped part of the study, on the method section, the difference was striking. They rated them 2 times as high if they agreed with them compared to if they were opposite relative to the conclusions. And I'm going to risk peril here by stopping sharing so I can actually share the second poll and see if that comes up. Nope, I don't think it's going to happen. All right, well, I will just illustrate it then. So give me 1 sec. I'll go back to sharing. All right. So the initial poll that you participated in was actually one that was conducted by Amos Tversky on a principle called framing. And essentially, had we completed the poll, the idea is that depending on how you frame the question with the exact same statistics, you will get different answers. So he went to one classroom, literally full of half the Harvard Medical School students, phrased the question in the same way I had sent it to you, which was around survival, and 84% took the treatment. He then phrased the exact same question, but in the context of instead of 90% survival, 10% mortality, and only 50% took the treatment, even though those numbers, of course, are the exact inverse of one another. And so undoubtedly, we would have not demonstrated that here. Undoubtedly, the numbers would have been the exact same, but it's the idea of framing. And it's really kind of one among the group that I like to call anchoring bias and its friends. So anchoring bias is the idea, or what Kahneman would call the general category of priming, which is sort of giving weight to your initial information or impressions and not adjusting from that initial anchor. So my favorite, of course, from ours is preeclampsia. So, a 40-year-old G1 comes in with a couple of high blood pressures, and then you're automatically calling it preeclampsia. And then their blood pressures kind of go down. And so somebody's like, well, oftentimes, it's intermittent vasospasm. So we see that. And then you finally get their labs back and there's actually no protein. And then somebody's like, well, 15% of the time, preeclampsia doesn't have protein. So it's that idea of just sort of pinning ourselves to that initial diagnosis. The framing effect we sort of talked about, and we'll talk about it later about other evidence sort of outside of medicine, premature closure. So this is the idea that, they came in, let's say it was COVID, they were positive for it, they were tachycardic, but then we missed the fact that they were actually also having a PE because that was sort of our initial anchor diagnosis. And then last, the bandwagon effect, which I don't think any of us who sit in labor and delivery need to have explained, but it's the idea that once a momentum has sort of taken hold, it's actually very hard to change that trajectory. And then last among our cognitive biases, the idea of representativeness bias, or the assumption that something that seems similar to other things in a certain category is itself a member of that category, or its flip side, ascertainment bias, which is to shape your decision based on the class into which you categorize a person. But again, how does that affect us in real life? For example, patient counseling. So this is truly one of my favorite studies, again, of our own. So what they did was they sent out a bunch of standardized patient videos, and each participant in this study was shown one of these videos, 524 OB and family medicine providers. And they really just asked them one question, which is, would you recommend an IUD? And then would you recommend it if you had risk factors for an STI? And I think, as you can see here, the pictures are really worth 1,000 words. The only thing that they changed among the videos that they sent, each person only got one video. The only thing they changed was race and sort of perceived socioeconomic status. And what they found, and I'll be sort of intentionally coarse here, is that looking at just the white colors bars, if you appeared to have education or money, the degree to which an IUD was recommended did not differ by race. If you look at the purple bars, if you were poor, you were allowed to have babies if you were white. But if you were Black or Latinx, really no more babies. And then now focusing on within race differences, purple versus white bars, the only race to not have a difference by socioeconomic status were Latinx patients who were categorically recommended to get IUDs. So we'll sort of nibble on that for a bit as we wrap up this section and segue over to our next, or real life disparities. And so what is a disparity or a disparity population? So per the NIH, it is one in which there is a significant disparity in the overall rate of disease incidence, prevalence, morbidity, or mortality as compared with the general population. And we need to recognize that these disparities happen at multiple levels, right? At the level of the health condition, for example, hypertension in Black patients. At the level of the health outcome, so maternal mortality being increased in both Black and Latina patients, or at the level of the health service, i.e. poorer patients being less likely to be able to access prenatal care. And while we consider these disparities, particularly ones along lines of race and ethnicity, I'd encourage remembering this, that race is not a biologic category that naturally produces these, but rather a social category with staggering biologic consequences. Or as I've heard it put simply, race is a risk factor for racism, and racism a risk factor for adverse health outcomes. So then in considering then where are the disparities in our own field, we'll sort of focus on these: maternal mortality, infant mortality, and cesarean delivery. But to be clear, there were many more than this that we could have looked at. So Black women are more likely to get episiotomies. Latinx are less likely to get epidurals, with this even greater among those with low English proficiency. There's lower educational attainment associated with less good management of gestational diabetes, and economic factors are at play as well, where poor women have higher rates of infant mortality. And even when there was a higher incidence, such as preterm birth in Black women or aspirin in Black women, they are actually still less likely to receive the health service, whenever it was progesterone, or in the case of aspirin. So I hate to say, there are many more we could discuss, but we'll start here. So maternal mortality, as we know, is already a source of embarrassment. I understand that the most recent data might question this, but I think that any number that's not zero is still a source of embarrassment. Black women, also represented here in the dark purple over each of these time periods, also have consistently higher rates of maternal morbidity and mortality. So whereas the rate is 13 per 100,000 white women, it is 42 per 100,000 Black women, or over threefold as many. And as you can see, it has not budged. And here's the thing: education, as we know, so often a surrogate for socioeconomic status, healthcare access, etc. In some ways, it is protective. Comparing dark purple bars across lines, we can see that Black women who graduated college are better off than those who only made it through high school. But it worsens actually the disparity, i.e. again, that rate ratio is more pronounced in comparing how they do compared to their white counterparts. The reasons women die also differ. So both groups have cardiovascular coronary disease near the top, but Black women are more likely to have cardiomyopathy or hypertension disorders, and white women more likely hemorrhage and infection, which to me potentially suggests under or misdiagnosis in Black women. Black and Latinx women also carry disproportionate burdens of severe maternal morbidity, the surrogate endpoint before mortality, because again, while they represent a smaller proportion of total deliveries in this country, they represent a disproportionately higher amount of SMM. So then moving on to infants. The overall infant mortality rate has gone down, yay us, but as you could probably guess from how this talk has been going, while it is good news, we bring it up because, again, the disparity is still there. So as you can see in the black line, the Black infant mortality rate is higher than the white infant mortality rate. But again, it illustrates that relevant statistic, the disparity index, or focusing on that multiplier. Because drilling down, while the total number has gone down, the multiplier has been stubbornly persistent and, in fact, even worsened. And then last on the list, cesarean delivery. So we know, sort of all comers, that this differs. But what this study showed so nicely in a really large database study was that even after adjusting for all of those factors which could sort of biologically explain the etiologies for these differences, those differences persisted. So after looking at age, BMI, diabetes, gestational age, hospital, et cetera, the differences persist. And it shouldn't surprise us because actually even the reasons for performing the cesarean delivery differed by race. So if we zoom in on these a bit, many of them are quite objective. You know, the baby's butt down, the placenta's on the way, not much to do about that. But the most subjective among them, which I would make the case, is non-reassuring fetal heart rate. Well, not surprisingly, when I sort of reveal to you which category gets the most, it is highest among Black and Latina women again. So those are just a handful, of course, of the said disparities facing our patients, and we are certainly working on it. But moving on to sort of our final topic of today, the machine, or in other words, what happens when these biases get coded in, when the behavior of our past become the recommendations of our future. So I'm going to pause now for one last thought experiment / water break. So what happens when we take a racial disparity, let's say cesarean delivery, and actually turn it into our calculator? And this is not at all in the theoretic. This is in fact an email that came to me back in 2020 around the EPIC and wanting to see if we wanted to put the Grobman model, the Grobman score for VBAC into our electronic health record. So I'm going to pause and ask you to think to yourselves or put it in the chat what you think might have happened. So I would say that we did not put it into our system, and it was sort of before a lot of the hullabaloo around GFR and then how that spread made these biased calculators sort of more brought to light. And I'm very glad that we didn't. And the reason is because, right, we would expect it to potentiate that bias. As anybody who knew sort of the old VBAC calculator before they changed it, when you clicked African American yes or Hispanic yes, God forbid you're both, it would drop your predicted probability of a VBAC lower. And the presumption was that this represented underlying structural racism. And so by then suddenly now recommending to a patient and also seeing it yourself, having your sort of number look different like that, having it look lower, everybody's going to potentially sort of set yourself up for the repeat C-section or failed TOLAC. And the thing with this coded bias, as we now know, is it's very much sort of already there. So this paper by Vyas, who I believe was a med student at the time of writing it, really went down like a firing squad, specialty by specialty, filling 3 pages of the New England Journal of Medicine with ways in which race inclusion in algorithms, large and small, is already adversely impacting our healthcare. And so what in fact has happened in other systems when we bake these algorithms in? Maybe one of the bigger problem areas, enough so that it's got its own Netflix documentary, is in the space of facial recognition. So most facial recognition software is coded based on a large big database called ImageNet. And ImageNet itself is heavily populated with images from Flickr. And so for those who used Flickr back in the day, chances are you are, well, a white dude. There was very little racial or demographic variety in the Flickr database. And so the training data was very heavy on the statistical bias, meaning it was really just a matter of time before ultimately things like this happen. So this is the story of a gentleman in Michigan, and there have now been a dozen cases, including one of a pregnant person, where facial recognition was used to incorrectly apprehend somebody. And so the police came, they went to his job, you know, pulled him aside in front of all of his friends, his coworkers, his boss, put handcuffs on him, and then ultimately finally brought him to the station, and showed him the picture. And they sort of describe him in this article, literally holding up the photo to his face and asking the police officer, "That's not me. Do you think all Black people look alike?" And in some ways, while this was incredibly dangerous, at least it was apparent, right? He could literally hold up that photo and be able to sort of reconcile like what the machine said with what our eyes say. What happens, on the other hand, when it gets a bit more baked in? So I'm going to spend a few minutes talking through this viewpoint piece because I think it does a really nice job of describing where we are. So as a brief reminder, although I don't think any of us escape it these days, what is artificial intelligence? So to me, the simplest, almost all-encompassing definition is basically computers doing what used to require a human brain to do. And so that's the broad grouping of artificial intelligence. Machine learning within that is the computer learning without need for explicit programming. And then deep learning is when it finds patterns on its own without a predefined outcome. And so what they asked really in this article is, where is the potential for bias whenever we introduce AI? And so first they go through sort of this discussion of different types of bias and the ways that can make its way into healthcare sort of more broadly. And then second, how AI could quickly take a little bias and make it worse. And then ending with this sort of more optimistic outlook of how perhaps AI could make us less biased and how we could do the same for our AI. So then in terms of the type of bias, in this case, not like the cognitive one that we focused on earlier, but rather the definition calling it just systematic error, we'll focus on the second column. So there are basically statistical, social, or both. And statistical bias is just the idea that it's not going to work great for you because the study wasn't built on you, right? The classic example of this is the Framingham Risk Calculator to predict 10-year cardiovascular risk. Since it was developed in Framingham, Massachusetts on almost entirely white men and women, it does a great job for almost entirely white men and women and does really poorly at predicting outcomes for others. The social bias is a bit more ew. So this is sort of the idea of when we consider how things get charted in EHR or even diagnoses that are made. So we know that at baseline, for example, if you walk into an emergency department with pelvic pain, you are twice as likely to get diagnosed with pelvic inflammatory disease. If you are Black, you are twice as likely to get diagnosed with endometriosis if you are white. And this is sort of a way to describe the implicit or cognitive biases that we talked about earlier. And then, of course, the last way systematic error can creep in is both, right? So there's missing data, let's say, due to a social determinant of health, so that poorer patients, for example, have less access to care. They get this double whammy because their worst outcomes are also literally not represented in the population. The second reality, though, that we have to consider is that AI and its implementation has the very real potential to make bias worse. So this is an idea that they touch on, but I think is really beautifully summarized more concisely by Kathy O'Neill in her book, Weapons of Math Destruction. It's simply this idea that the types of algorithms that are most potentially harmful are those that can scale, that are opaque, and those that have feedback loops. So for example, whereas one racist, ED doctor or a gynecologist can overenthusiastically diagnose PID one at a time, an algorithm, of course, can do it in legion. While that gynecologist can be chart audited, an algorithm is often proprietary and sort of shrouded both for commercial reasons and for HIPAA reasons in this sort of black box. And again, while that one gynecologist can hopefully just stay unto him or herself and society and culture can change to become less racist, an AI system might in fact get more and more racist as it continues to learn, then get validated into the same way of thinking, particularly in these more relatively subjective diagnoses. Barik also brings up another fun one, which is automation complacency. So it's kind of the opposite of the alert fatigue that we always hear about. So y'all might know the story that the first guy to unfortunately die in a self-driving car, in fact, hit the person because he was at that moment texting about how cool it was to be in a self-driving car. So on the glass half full side of things, how can maybe AI can make us less biased? So I thought this was a really silly part, but honestly, couldn't resist doing a bad Photoshop job with it. So it's the idea of this real-time bias identifier. So let's say we know in certain circumstances, say towards the end of the day in clinic, that system 1 starts to take over. Maybe then you place an order that's not your best self. Maybe you get this alert. I don't think that'll ever really exist, but I just thought it was fun and I like playing in Photoshop. So what can we instead do now? So whenever you are making, any sort of model, and this doesn't have to be like any sort of fancy model, logistic regression, all of those things count as models. So what can we do now to sort of make all of these models less biased? Well, step 1, we should train on more unbiased data, right? So vitals are vitals, so should be potentially trainable. It's also ideal to train on data upstream of clinical judgments, i.e. from triage or data from the first hour. And then, of course, there's a potential for oversampling intentionally. So if we know we don't have enough Black patients, for example, then you can try to oversample when building the algorithm. And then the idea of knowing our own weaknesses, that we built these algorithms large and small and can only expect that we're going to keep sort of doing this bias, so let's keep an eye out for it. So the ProBest guidelines or prediction model risk of bias assessment tool is a tool for assessing risk of bias across 5 domains: participant selection, outcome, predictors, sample size, and analysis in prediction modeling studies. Sensitivity analyses are really key, and I think that really need to be published with every single model that goes out there, where you vary populations' outcomes to see if then the model differs along lines that we know matter, like race, insurance status, et cetera. And then, of course, mandating post hoc auditing, right? So we do not accept opacity in medicine, right? We don't, other than aspirin. But otherwise, we say that we have to understand the mechanism behind it. And I would suggest that, in fact, these algorithms should not be any different, that we need to be able to get in there and audit them. So then putting it all together before we get to our epilogue here, we've talked about the nature of how we acquire and process data in systems 1 and 2 thinking, and how our own experiences inform our cognitive biases or blind spots and heuristics or shortcuts around these. We reviewed some of the disparities that continue to plague our field and touched on how this might impact our field as we find these calculators more and more built into our work. And so then the question is, what do we do about it? So let's sort of take this back to the practical. None of us went into neurology here. So I'm going to start by saying this. So I get that by fixing any personal cognitive biases, we are not fixing all of this. And that at the same time, calculators and automation aren't getting avoided, but if anything, are becoming more a part of our life. And I would suggest, though, that there is some hope for each. So this is going to be the last of our cognitive bias exercises. So if you will, indulge me and take this one for a spin. Okay, and the next one. Okay. So many of you are experiencing that this sort of quote unquote bias that you walk in with is your ability to read, your interpretation of the words conflicting with the task you've been given. So reading, again, is automatic. It's system 1. The exercise that you performed, on the other hand, was not. So what does that look like in the real world? How do we activate that system 2? So perhaps the leading expert on this is Dr. Jennifer Eberhard, who has a new book detailing her experience interrupting bias. And one example she gives is the Nextdoor app. So who on this WebEx is on it? Sit in silence if you're on Nextdoor. Okay, great. So all of you. So sorry to build in jokes at 5:30 a.m. here. So it is sort of like a Facebook for your local neighborhood or 10-block radius. So it's everything from, right, it's Labor Day, there's no trash pickup, to my kid's lemonade stand is out there. Unfortunately, what you quickly recognize if you are on this is that there are also reports, especially when I first joined back in 2016, that are really where they deem suspicious behavior as just man sitting in car while black. And so what Dr. Eberhard did, she was contacted by their CEO, and the CEO was like, this is really bad. How do we fix this? And so she really introduced this idea of a point of friction, essentially something to slow people down, which is like anathema to all things like tech industry wants to do, right? But she said, we need to introduce this friction. So she asked them in sort of the classic, instead of the classic, if you see something, say something, to instead add, if you see something suspicious, say something specific. It also now asks you for a detailed description of the subject. For example, Latino won't do, otherwise every Latino man in a X mile radius is suddenly a subject. And then last, they actually just put up the definition of racial profiling, and they state that it is prohibited. And just by taking these actions alone, they decrease the disparities and they decrease the number of those sort of problematic reports by over half. Another really fascinating study she did interrupting bias was with the Oakland police. So the Oakland police was having sort of differential degrees of traffic stops by race and ethnicity. And so the way she used machine learning was, instead of this time to sort of change the tech, but rather to actually process the body cam footage. So she had every police officer, no matter what, every traffic stop, run their body cam, which would be, of course, impossible to look at for any human eyes or even to categorize, even with a big old research grant. But what they did was they instead used a machine learning system, which also sort of made the officers feel less watched in some ways, to process all of that body cam footage. And what they were able to demonstrate was that they speak very objectively and across lines of race and ethnicity for the officers. They speak to suspects differently by race. So you can see that in white stops, they were more common to apologize, to reassure, to use their last names. Whereas in stops of Black persons, they were more commonly telling them to put their hands on the wheel, to ask, what they were doing, to use informal titles, that sort of thing. So showing them that objective data and then retraining off of those sort of objective issues, what they were able to demonstrate then was, again, between 2016 and 2018, a significant reduction in overall stops and a significant reduction in the disparities of their stops. So then what does all of that mean for us? How do we operationalize that system two in healthcare? And so from the Joint Commission of all folks, they say that the sort of step one is recognition and awareness, which I think thankfully in the last several years, we're getting there. They also suggest that we enhance our reasoning skills, specifically through what they call reflective reason, which is sort of thinking through backwards how we got to a conclusion and checking ourselves along the way. It's sort of like the if you see something suspicious, say something specific version in healthcare. In addition, they also take into account both frameworks and work system conditions in considering this. So if we think about something in other patient safety things, a timeout is essentially exactly that, right? You give a framework for ways to consider all of the things that could sort of go wrong in surgery, wrong site, et cetera, antibiotic intolerance, and that framework is there before every single surgery, sort of no matter how acute even. Is an organized way, and it also enhances the work system conditions around it, right? You don't show up to a room like fuming because somebody's trying to waste your time with a timeout. It is just the expectation, and it is a part, again, of organizational culture. And so great, we're all debiased, good for us, but how do we actually address those algorithms? And the good news is that this is actually a very, very active area of interest and research. Fact-based AI, i.e. fairness, accountability, and transparency, is now a new movement within the AI community. And in fact, as an awesome epilogue to the coded bias story earlier around facial recognition, Dr. Buolamwini, the one who was in the right side of the screen, who the algorithm literally couldn't see unless she put a white mask over her dark skin, she has now formed the Algorithmic Justice League, which meets apparently over brunch. It looks like a great brunch, and actually roots out the bias in your algorithms post hoc. And honestly, in many ways, it's understandable that it takes a league because there are actually many potential spots, again, where this can go wrong. So we talked about how, there's maybe oversampling to fix some of that representation bias that was existing in the Framingham study. But what do we do about those historical biases that we need to unpack sort of from the get-go? But really at every step of this, the aggregation, even the evaluation, we need to think about these really critically before we ultimately then codify these models into something that we can't unpack so easily. And in many ways, this is where we sort of get a bit philosophical, where you accept some degree of quote unquote trade-offs to accuracy to make the world a better place. So let's, for example, pretend that there was still bias in our VBAC calculator. One can't know because they didn't actually publish the substratified data. But anyway, let's pretend that there was still bias there. So statistical fairness, essentially we can use a few different methods for it. So you can do predictive parity, which is sort of an equal positive predictive value, i.e. the probability of having a VBAC can be standardized among all races. Statistical parity, in which predicted probabilities ultimately get equalized. So for example, all races having the same predicted. And then equalized odds, which actually incorporates both predictive parity and fairness and adds a requirement for an equal false positive rate, i.e. that all races would be given an equal opportunity to attempt a VBAC. And then, of course, there's like sort of fancier machine learning methods for this one called fairness through awareness, which is a similarity-based measure in which similar individuals, people sort of being all other things being equal, then should all have the same classification, i.e., the same 40-year-old G1, all of the sort of list down by white or black should not have a different prediction in the end. So I know that was a bit of a whirlwind, and apparently waking up this early gets me talking even faster than usual. So I hope that was helpful in framing our systems of thinking, acknowledging the harms that can come from an over-reliance on system one and the disparities that plague our own field as a consequence of this. And ultimately then how, if we don't actively interrupt these biases, they have the potential to magnify as the pesky algorithms like those that I work on. And so I will end there with both a gift and a favor. The gift is the bigger QR code on the left, which is that I don't do reference lists because I think it's silly. Nobody can read them and nobody remembers what the reference was from before. Instead, I save all of my PDFs from articles to a Dropbox, and that is the QR code for the Dropbox. You can also screenshot it if you're watching on your phone and then click it later. And then that's the URL if you don't like QR codes. And then on the right is actually a survey that we are doing to really better understand how physicians feel or think or perceive integration of these algorithms, this AI, into clinical care. So if folks are willing, I would love to have you consider responding to our survey.
Thank you, Dr. Wong. Thank you so much for that excellent talk. I see that Dr. Bayat has her hand up.
Thank you. God, thank you so much, Dr. Wong. I feel like I really thought you were cool just from reading your CV, and now I think that you're really awesome and would like to be friends.
You just have to introduce me and start the questions every time. Okay, I'm going to carry you around, Dr. Bayat. Go ahead.
I'm like, my mind is just blown, and I think there is like one thing that's really jumping out to me, and that's the data that you had presented at the start of the talk on the overconfidence kind of phenomenon. And it's just so interesting to me because I feel like we focus so much on, you know, imposter syndrome and making that a pathologic diagnosis and what we need to do to fix that. Whereas it seems like the problem might be overconfidence of other people, but that was just a thought I had. A question that I have for you.
I'm going to answer that first
Sure.
thought by suggesting there's I think that we all or many of us read Lean In and we're like, oh God, imposter syndrome, like that's all of us. There's a really good article that is like therapy to those of us with imposter syndrome called Stop Calling It Imposter Syndrome, because it really reflects that that we need structural change. Because actually having quote unquote imposter syndrome is more a reflection of that. So I'm just going to micro answer that one and get one more reference that's not in the
I'm going to
PDF.
start calling some things overconfidence syndrome. So thank you for that language. I appreciate it. The question I had, I know that we have a lot of quality metrics and safety metrics that we use in OBGYN. We all get our NTSV scores. I'm wondering if there's any kind of measure equivalent to that that's being used to sort of assess how healthcare providers are doing when it comes to, their own outcomes and how biases impact their outcomes.
God, that's such a good question. And
that you think, would be useful at any point.
We might have to steal that as a multi-institutional research idea because we do independently, I should say, we are generally really skittish about reporting any data where apart from NTSV, quite frankly, where the unit of analysis is the provider. And I think that that's actually ended up hindering us. So for example, I can absolutely think through our C-section rates, we have data by race and ethnicity. We are, timely treatment of hypertension, quality metrics. We as an institution break it down along lines of race and ethnicity and have been fortunate to show a reduction over time in our racial disparities, no doubt due to implicit bias online training. I'm just kidding. No, it's terrible. But fortunately, I would say we've all been more cognizant, and so we've seen those disparities change. But I have never actually seen it at an individual provider level and trying to use that as an instrument of change. And I think that would actually be incredible.
Yeah, I just keep thinking like, in my Epic, I always have like a percentage score. I don't know, like how often you have reviewed her medical history, or her allergies or something like that. I would love to see if there could be something, like I don't know, we're a little bit racist today or something along those lines.
I think that would actually be really incredible. And I think it would be really insightful for folks to receive that information, of course, in sort of a safe, ego protecting way. I'm actually going to stop sharing just so I can see folks. Hopefully everybody who wanted the PDFs was able to get the QR.
I will definitely email you because I think that you're really cool. So thank you.
I see that Dr. Goldberg has his hand up.
Dr. Wong, that was really amazing. I'm not surprised coming from a Chicago lying in resident graduate, of course. How How frequently do you give this talk, and how widely do you give this talk? I think here at Robert Wood Johnson, the medical school, we hear a lot about our biases and bias training, and I hope that we're making progress. I feel like I am. I'm recognizing a lot of the things that you're saying, but I want to know how widely this word is getting out throughout the whole country. And are we, as you saw it, and as you said, some of the slides and some of the data may be a couple of years old, and are we making progress here in 2023? But thank you again.
Yeah, absolutely. I would say some. I think that oftentimes, even as we think of the AIM bundle, sort of recognition and awareness is step one to much of this. So I think that we are sort of being held to task, which is really just step one in all of this. And I'll say that the answer is I actually probably have given this talk more than any other talk that I've given, largely because certain states, including California being one of them, have started to mandate implicit bias training. And actually, we had a specific bill, SB 646 or something like that, where they mandated it for anybody taking care of pregnant people. So it was specifically one of our senators or congresspersons focused it there, which one would make the case that means everybody, but nonetheless, it was targeted to OB physicians, nurse midwives, L&D nurses. So I think that we are broadly getting more aware of this issue, but we still have a lot of work to do. Now I'm seeing the commentary. Yes, thank you you're correct. That with the VBAC calculator in place, we expect that the counseling would change. And he died yesterday. Was that in reference to Kahneman? I didn't know that.
All right. Well, if there are no other questions, Dr. Wong, thank you again for this excellent talk.
Thank you so much. It was really fun.
Yes, thank you. And so we'll end it here. I hope everyone has a safe and productive day. Thank you.